Good morning, everybody. It is Friday, TGIF to everybody, August 23rd, and we are having I've been looking forward to this webinar for quite some time, GEMT cost reporting insights and lessons learned with our friends from PCG. I'm Kevin Joels. I'm with Lawrence Douglas County Fire Medical in Lawrence, Kansas, and I'm the EMS section chair for the IAFC. Want to give an early thank you to our sponsor, Public Consulting Group, affectionately called PCG in our world. We appreciate their collaboration and their sponsorship, not only on this project, but numerous other projects that we have going on with them within the fire industry, but then also with IAFC. So we appreciate their work. Before we begin, the audio is being broadcast using voice over IP technology through your computer, speakers, or headset. Please make sure your speakers or headset are turned on and volume is turned up. Audience microphones have been muted. If you experience technical difficulties, please contact the IFC support at webinars@ifc.org or via the chat function. There's a chat and QA and handouts if you look up in the top right of your screen to be able to navigate through all those features. There are handouts for this presentation, so make sure you check those out and take them with you at the end of the presentation. A couple of upcoming events that are left in 2024. Symposium in the Sun, which is in Clearwater, Florida. And then Technology Summit International, or TSI, which is December 5th and 6th in Oklahoma City, Oklahoma. Again, today's title for the webinar is GEMT Cost Reporting Insights and Lessons Learned. And with us today, we have Alyssa and Garrett from PCG, and we'll let them go ahead and get this started. Thanks for attending.
Excellent. Well, thank you so much, Chief. Thank you, Nan, and thank you to the IAFC for having us today. I'm Garrett Abrahamson, been with PCG for 15 years and working with the EMS and fire for the last decade. Alyssa, I don't know if you want to introduce yourself before we jump into the agenda.
Sure. Yeah. Thanks, Garrett. And thank you, IAFC, as Garrett said, for having us today. My name is Alyssa Narode, Associate Manager with PCG. I've been with the firm for a little over 9 years now. And since 2016 have been supporting EMS supplemental payment programs. So happy to give a refresher and give you some more insights today on what's been going on since we first gave a presentation almost a year ago. I think it was in October of last year when we did this, but we got some new insights and looking forward to walking everyone through anything.
Excellent. Yeah, so we'll give a very brief primer on ASPP for folks in case you haven't heard of them. Again, I know we have people from around the country, so you may have heard this as GEMT or PEMT, SEMT, but really at the end of the day, they're all the same core ambulance supplemental payment program. So that's the terminology that Alyssa and I will use, are those ASPPs. So we'll go very quickly through those, assuming if you are here, you've likely at least heard of them and are up to speed on that as well. Alyssa will dive into some of that CMS guidance that, again, we now have a little bit more history on that came out 2 years ago. And then we'll talk a little bit about the future of ASPP programs and specifically opportunities within the managed care side of the Medicaid programs and what efforts are underway to preserve those GEMT or ASPP programs. So again, really want to say thank you to the IAFC. We're partnered with them, and IAFC has been a great partner to us, and we really appreciate all that they do for you all and the community. Just very quickly about PCG. We were founded back in 1986, so almost 4 decades worth of experience in the public sector. That's really our core. Anywhere that the state and federal governments meet and intersect, that's where we operate. So from a healthcare standpoint, Medicaid is one of those programs that we have almost 40 years of experience with. We've worked in all 50 states. You can see on the map there. We are active in 49. So if we have anyone from North Dakota on the line, let us know. We'd love to be able to color in North Dakota at some point again. And over the last almost 2 decades, beginning in 2006, we started working with to build the first EMS supplemental payment down in Texas with the city of Austin. Since that time, we've worked with 550 fire and EMS departments across 21 states, and actively working with 550 departments in 21 states. So again, a quick primer on ambulance supplemental payment programs, why they exist. I think it's no surprise to any of you that providing a transport costs significantly more than you are reimbursed to provide that transport, especially for Medicaid recipients. And you're transporting at a significant loss when billing for Medicaid. So beginning in 2006, I mentioned that program down in Texas. It was something called a Certified Public Expenditure Program. And that allowed the state of Texas to draw down additional federal dollars and send that to the ambulance service providers. Since then, over 30 states have implemented a program or are currently trying to get past a supplemental reimbursement program for those emergency service providers. There's the maps of the dark blue there. Those are active programs, active supplemental payment programs for ambulance service providers. And that magenta color are those states that either are somewhere in their journey of getting a program approved. So again, the reason for a supplemental payment, why they exist, and how they help. Again, these are for Medicaid recipients and Medicaid transports in an effort to increase the reimbursement for providing that transport. Some of the things remain the same. You continue to bill Medicaid for those transports. You continue to receive interim payments, which again, usually somewhere in the ballpark of 20 to 30% of what that costs. That interim payment is leaving a 70% gap on that transport. And so that's where an annual cost report comes in. And most people that have participated are familiar with that annual cost report, ultimately receiving a supplemental payment through that cost reimbursement process. So it's those last two elements that are different for states that have an ASPP program. Again, everyone continues to bill for Medicaid and receive those interim payments. So very quick Medicaid 101. Medicaid is a joint program between the federal government and the state. It is funded by both federal dollars and state dollars. Supplemental payment programs allow the state to draw down those additional federal dollars for the healthcare services that they're providing without increasing the appropriation on the state side, because you're drawing down as a public entity those costs that had already been expended. So in our example, you provide a transport at a cost of $1,200. You submit your claim either in-house through a billing partner, and you receive $200 for that. That's great, but it leaves a gap. It leaves that gap of $1,000 for providing that transport. So you've lost $1,000 providing that transport. Drawing down the additional federal dollars, in this case, Florida as an example, the federal government picks up 60% of the cost of Medicaid. The state picks up 40% of the other 40%. So as a public entity, you've provided $400 worth of that service. You've raised local tax dollars, and that certified public expenditure allows you to draw down that additional $600 in federal funding. And that's the core mechanics of supplemental payment programs to date. Again, sort of another visual of that. You provide services. The state Medicaid program is going to collect those annual cost reports, submit that to CMS on a CMS 64. That's the form that they utilize to indicate the expenditures, and then drawing down and redistributing that back to the providers that submitted the annual cost report. So in order to complete that, multiple elements of data are collected. Again, if you've submitted a cost report, you know this. It's going to look also very similar to the Medicare ground ambulance data collection that everyone had to go through. So even if you haven't participated in an ASPP program, a lot of the core data elements are the same. The ultimate result and how that data is used ends up looking very different. So for the supplemental payment programs, you're going to see expenditures by the cost center, CAD or computer-aided dispatch information to get down to how much time is spent providing medical services, depreciation for all your large assets, federal funds. Again, if you've received other types of federal grants, capital usage, so the square footage of your physical plant, all that billing data, not just to Medicaid, but all payers and how many transports you provided throughout the course of the year. And then some additional elements on indirect cost rates, sort of that overhead cost associated with the city, town, or county. And then FTE hours, right? How much time is spent providing services. So that's where we've been the last nearly 2 decades. Mentioned it at the top. It was about 2 years ago that CMS submitted additional guidance related to supplemental payment programs. And now that we're a full cost report year and headed into a second cost report year, circling back with this group to provide a little bit of insight on what we've seen. And I'll toss it over to Alyssa for that. Oh, first, sorry, a poll question. I didn't pause long enough for the poll question. Thanks, Dan. Please take a second to answer yes or no.
Yeah, so the question, I'll read it out loud here, is how many of you are aware of the letter that was sent by CMS back in August of 22? So we actually are on a 2-year anniversary of this letter and guidance coming out. Okay, so it's about a 50-50 split. But it's good to know that there's about 9 folks on the call right now that have not heard of this. So we're going to dive into this a little bit. We did provide some summary about this last year as well. But for background, in August of 2022, CMS issued an informational bulletin which addressed some of their, what we would consider, concerns about Medicaid supplemental payment programs for emergency medical transportation providers, right? Anyone that's participating in what we call a GEMT, PEMT, ESPP, EGAS now in New Mexico, or an ASPP in some other states as well. Everyone likes to make up their own names for these programs. But what the letter was trying to get at was clarifying what they consider, or what they want to consider, allowable costs, what the templates are that should be used and should be consistent with federal cost allocation guidance, tried to provide additional clarification on costs related to fire and rescue and what they would consider unallowable, and also just starting to talk about if they believe that the proper way to allocate costs when you do have these fire and EMS expenditures that are hard to figure out exactly what should be allocated, if computer-aided dispatch or CAD data is the appropriate way to be allocating those shared costs between fire and EMS. So from there, we have seen some changes over the last couple of years, and we're going to get into that. But also what we've seen since the letter came out is, and even before that, is we've had some states, 5 still, that, we gave an update on this last October. Nothing has changed in that last 10 months. So those 5 states are still awaiting CMS approval of their programs. And for folks that have been able to receive funds from these programs, you know how beneficial these programs are. They help you hire staff. They help you buy new equipment, implement new trainings or care coordination that you want to do within your state or within your department. And so now that we're seeing a lot of changes, or we've seen a lot of these programs pending, those dollars tend to diminish, or those dollars aren't coming in at all. So as we started to get into it, right, the summary of the main issues that CMS has concern with is trying to figure out what costs are actually incurred when somebody responds to an emergency call and responds to the scene. They've also looked into potentially looking at time studies to determine how much time should be allocated and spent providing those direct medical services to patients. They also want to disallow readiness time, and I will provide a slide on this. But we just saw this actually happen in Texas with the fiscal 23 cost reports that were just audited. And then also similarly, limitations on allowable indirect costs. And we're already starting now to see the impact of this letter on some states, specifically Maryland, Missouri, and Texas. So we will highlight that. So first and foremost, disallowance of first responder costs. What CMS is really trying to do is determine how much time is spent on scene, and really trying to dig into when the first responder touches the patient. So not when they are at the station, not when they're driving to the scene, but when they actually arrive and start providing services, all the way through to when they clear the call at the emergency room. We've already seen in some states that they are starting to do this and dig into this through the CAD data. And I'll get into that a little bit further in the slides. Time study requirement. This has not happened yet. We have still seen this as a recommendation in some of the pending state plan negotiations. But since there has been no state plan that has been approved in the 5 pending states, we are still waiting additional guidance from CMS on what that type of time study looks like, or what they would allow to be acceptable as a time study. But we obviously know that, sending a moment in time, if a paramedic or an EMT is on a call and saying, hey, what are you doing right now? Is really not feasible for this setting. Because if you are in an emergency situation, you can't respond to a random moment that's sent to you to your phone or to your email at that time. So we're still trying to dig into this with CMS and determine if this even makes sense as a requirement for these types of programs and to be applied on the cost reports. So the other one is disallowance of readiness time. So if they use a random moment time study, this would allow them to also discount and draw down to exactly the time spent providing direct medical service. We did see a new methodology applied in Texas during the desk reviews this year. And I will get into that in a little bit on a slide of how Texas decided to figure out and apply a new, what they're calling a direct medical percentage, utilization percentage. But the impact of what we've seen from them disallowing readiness time or any of those indirect costs, whether it be training, education, anything like that, that would still support or indirectly support the direct medical service, we're seeing drastic reductions in the supplemental payments that providers are receiving. And then to piggyback off of that last point, CMS is also looking to limit indirect costs. So a lot of times in other settings, whether it's hospitals or school-based health services or even county-based mental health providers, CMS allows indirect costs, meaning, right, in order for you as a provider to provide a emergency medical transport and provide the medical services that are needed, you also have other departments that are critical to to that operation, such as dispatch, your finance department, your IT. You have to train your staff. And usually CMS allows all of these, or a portion of these are allowed in the cost report. And what CMS is taking a look at is wanting to only include costs that are directly tied to providing an emergency transport. And so, we can probably say confidently now what this impact is having on Texas providers, but we still have yet to see the full impact. And every state has taken a different approach in terms of interpreting that letter and making sure that their programs are following the guidance as they see fit. But we have seen some states now apply a more strict allocation of cost. And so specifically, and I wanted to highlight this because this does impact providers that we work with in Maryland and Missouri, is that there has been a CAD allocation change, meaning that first and foremost, originally when we started collecting data, we only needed dispatch time and clear time to figure out how much time was spent on a call. Well, over the last 2 years since this guidance has come out, we also have now been required to collect the time that the vehicles arrive on scene, as well as the time that they arrive at the hospital and then they're cleared. The reason that states are asking for this additional level of detail is because they don't want to include the time when it's dispatch, right? Don't include the time from dispatch to arrival on the scene, as well as looking at the hospital arrival to see, did that call, that dispatch actually result in an emergency transport? And the other thing that we are now collecting as well are these apparatus description lists, because right when you get a call and you dispatch vehicles, some of those are ambulances, but sometimes you also dispatch an engine, or you're dispatching, right? If a chief or multiple chiefs are coming, they're coming in their vehicles as well. And one of the things that we've seen in these two states specifically, Maryland and Missouri, is that now all of that time, if it's an EMS call and an ambulance responds, they'll include all of that time. But if it's an EMS call and an engine also gets sent, or another vehicle gets sent, that time that those vehicles were there is reduced by 50%. And so what we saw were drops from, from the 22 to 23 cost report. We saw a reduction in the CAD data and what was being allowed to be allocated. Some of them were as significant as dropping from saying, this provider A spends 80% of their time providing EMS or responding and providing services on EMS calls, dropping down to 60%. And if you're a large department, and even if you're not a large department, that has a huge impact if you are a fire and EMS based department, because it then discounts how much of those shared cost buckets gets allocated towards your EMS service costs in the cost report. And the specific example that I want to go into in Texas is that this past year, typically we get this guidance ahead of time. In Maryland and Missouri, we knew it was coming prior to submission of the cost report date. In Texas, we did not have this guidance when we completed the cost reports back in January. And what we saw just this past summer, and we just wrapped these desk reviews up a couple weeks ago, actually, is that they applied what they can call a direct medical utilization rate. And this new CAD template calculated the difference between arrival time on scene and the clear time for all medical calls. So it looked at the clear time in minutes versus the arrival time in minutes, and then multiplied that up by the staffing per unit. So we also had to collect how many employees were on each vehicle, converted that to hours, and then we had to also collect from our providers the total paramedic employee hours. So this was a huge lift, not just for us working for our providers, but for all of our providers to have to provide this after the cost reports were done, and make sure they had them. And the other thing I think is hugely important to point out is that some CAD systems don't have all of this data readily available. And so for some of our providers, if they didn't have a CAD system that could also pull out the arrival time and the hospital clear times and all of the apparatus information, we weren't able to update their CAD template, and to make these changes, which is now having a huge financial impact on them because we didn't have, they don't even have the systems. And so that's something, as we talk about, how can you get involved? What can you do as a provider or as part of the IAFC? Is we need to really be able to communicate to CMS that not every provider is the same. Not every provider has the same systems and reporting, dashboards, that CMS is looking for. And sometimes this funding can be used to implement, and purchase better systems, but they can't think that everyone is on the same, level ground in terms of reporting. And we try and work with the data we have. But I think what's the other thing we want to point out here in Texas, and I think the second bullet right here is probably you'll see the biggest impact is that this year alone, the total funding for Texas ASPP providers decreased from $325 million last year to an estimated $75 million this year. So we haven't seen the final settlement. We usually see that in a couple weeks in September. But this is going to have a huge impact. And these providers, right, the Texas program has been around since 2012. And so providers rely on this funding, right? It supplements their budgets. And it'll be yet to see, what this impact is. But, we were on a call yesterday with a member from IAFC where they flat out said, these reductions are going to cost, FTEs, which is a really scary thing to think about when we know that EMS is already understaffed and there's such large staff turnover rates. So we're hoping to not see this additional guidance trickle down into other states, but given that this came from CMS and Texas is applying this, we're anticipating similar guidance is going to come out in some of the states that have pending programs. But we're also hearing that CMS may look into states that already have approved programs and apply some of these methodologies. So all that to say is, we really want to make sure that providers are aware of what's going on from the national level, and are starting to look at their own reporting and how their program is set up, to understand, am I in compliance with all of this guidance? So in terms of what's next and how you can best prepare, this was the other thing that is looming out there, was that in 23, CMS said that they were going to do OIG audits. So OIG is the Federal Audit Bureau or agency from the federal side. We have yet to see them audit a full program. In Texas, there is a current, and it should be wrapping up soon, federal OIG audit of supplemental payment programs, but it wasn't just narrowed down to the entire Texas supplemental payment program. So some of our providers were audited as part of that program. And I can tell you that it was a lot of in-person visits. It was a lot of on-site. It was a lot of detail. I mean, CMS wanted the expenditures to tie down to the penny. So we haven't seen the final results of that, but we know that these audits are coming. And so if you are in a state where you have participated in a program and it hasn't been audited, our recommendation is save everything. For the providers we work with, we save everything on our end. But we know that some providers are probably not saving, their information that they completed a cost report 7, 8, 9 years ago. But in Florida, we are still doing fiscal 16 audits. So those were for costs associated with dollars in 2015 and 2016, right? So that's 8, 9 years ago now. So biggest thing is, if you participate in these programs, save all the documentation used to fill, that was used to complete the cost reports. Just like to highlight this here. These are the states that still have pending state plans. So Arkansas, Kentucky, Idaho, New York, and Wisconsin are the 5 currently. And, I think as Garrett's going to get into, what we're seeing and why we're seeing a shift, is we haven't seen any other states yet introduce a state plan amendment. And I think that's because states are also, right, Medicaid directors are watching this on a national level. And right, Arkansas and some of these other states have had these pending state plans since 2019. So they've really been, out there now for almost 5 years, which is pretty frustrating. It usually takes anywhere from 12 to 18 months, usually not 5 years. I kind of already went over this, so I don't want to spend too much time going into this. And obviously we have the slide deck readily available for you all. So the one thing before Garrett takes back over is we have a second poll. And the second poll here is, how many of you know the difference between Medicaid fee-for-service and Medicaid managed care, or Medicaid MCO? And the reason we want to ask this is to frame where Garrett's going with the closing part of our conversation here. So we'll keep it open for a second. And the reason we want to ask this question is because what Garrett is going to get into is that we've seen a shift in how we provide supplemental payments in EMS and for EMS providers. Okay, so similarly, I would say, more no's than yeses, but we'll get into that. So thank you for responding there. So Garrett, I will kick it over to you.
Excellent. Well, thank you so much, Alyssa. And as Alyssa teed up there, it looks like a little over half of the participants now responding that they are not familiar of the difference between fee-for-service and managed care. And depending on the state, that may make sense. So again, a little bit of Medicaid 101, sort of got to the funding a little bit earlier in the presentation. But Medicaid 101, there's really 2 different forms that Medicaid can take, 2 overarching forms that Medicaid can take. One is fee-for-service. That is where the state itself is paying claims for Medicaid recipients. So when you or your billing vendor submits a claim for a Medicaid fee-for-service entity, that's actually getting billed directly to the state, and the state is paying out of their MMIS, or their Medicaid Management Information System. More and more states, and within states, a higher and higher percentage, as you can see on the map, have moved towards managed care organizations. And that is an entity that is on behalf of this Medicaid agency, as the name implies, managing the care of those Medicaid recipients. So they are provided with a per member per month from the Medicaid agency. And then it's ultimately the responsibility of that MCO, that managed care organization, to manage that population. So they're receiving that per member per month. They are paying out the claims. So in these examples with a managed care organization, when you are submitting that claim, or your billing partner is submitting that claim, it's actually going to a third party. So some of the large ones, the Blue Crosses, the Aetnas, the Humanas, they all have their managed care organizations in various different states. And so it's actually getting billed to them who are managing the care. And as you can see, that dark blue, that real dark blue on the screen, those are states that have over 84% of the Medicaid population in managed care. And what does that mean? And how does that interplay with ambulance supplemental payments? ASPPs, as we've been talking about, in the intro and then through sort of updates on the guidance, have really focused in on certified public expenditures. And that is where, as a public entity, you're submitting that annual cost report that we talked about, and the state is ultimately drawing down those additional federal funds based on your expenditures and submitting that supplemental payment to you once they've drawn down those additional federal dollars. That is only relevant to Medicaid fee-for-service transports. So in states like Florida that have had a program for a number of years, in states like Texas, when you're talking about that fee-for-service population, it's actually a very small percentage of the Medicaid transports that you are providing. The vast majority, 3/4, maybe 90% of the time, when you transport a Medicaid patient, you're actually transporting someone within a managed care organization. So how does that differ, right? On the fee-for-service side, this is what we sort of outlined previously. You have that annual cost report. You receive that supplemental payment based on that gap between your cost and what you received on the state fee schedule. It's provider specific. So it is a supplemental payment that's coming back to you that is provider specific. That state share, as we talked about, is a certified public expenditure. As a public entity, you are certifying that you have expended those dollars providing services for Medicaid recipients. And it repeats on an annual basis. You submit a cost report every year based on how many transports you provided and the true cost of providing those services. The managed care side is a little bit different because you're now dealing with a third-party entity, a managed care organization. So managed care supplemental payments are a little bit different. They're tied to utilization and ultimately made on a schedule that's approved by the state Medicaid agency. It is not usually provider specific. It is an add-on rate that utilizes or that uses the statewide average for that provider class. So it's looking across the ambulance services across the state, not just looking at an individual provider's experience. Ultimately, those Medicaid payments aren't coming directly from the state. It's coming through that managed care organization. And the funding mechanism is a little bit different. It's an intergovernmental transfer. There are a couple states that use intergovernmental transfers on the fee-for-service side. That's the rarity. I'd say that's the minority. But on the managed care side, intergovernmental transfers are the funding mechanism through the Medicaid agency. And unlike a fee-for-service program that is, and Alyssa alluded to, the state plan amendment process, where 5 states are currently held up, the state plan on the fee-for-service side sort of outlines how the program will pay going forward. On the managed care side, that preprint is an annual process. And so that preprint gets updated each year with the program. So today, there are 3 approved managed care programs, Florida, Oklahoma, and New Mexico, and a number of other states that are exploring Medicaid MCO programs. So Texas, Missouri, Kentucky, Ohio, and South Carolina. Again, all states with a heavy concentration of managed care recipients. So the bulk of the Medicaid recipients are enrolled with one of those managed care organizations. So how does it work? Again, what sort of some new terminology, even if you've been familiar with a GEMT, a PEMT, an ASPP, state-directed payments and managed care organizations, preprints, all new terminology. So preprint is ultimately the submission here, as opposed to a state plan amendment. That preprint are usually submitted prior to the effective date, as opposed to a state plan amendment that sets that date and then waits for approval. Typically with a preprint, you are submitting that in advance of the effective date. And there's actually all preprints are now starting, I think about 15 months ago, all new preprints that are approved are posted up on the CMS website and are accessible across the board. One of the other elements about the directed payment is that you define the provider class. So typically that requires some type of submission, whether that's the same cost report. So again, in states like Florida or Missouri, where there's already a fee-for-service program, looking at utilizing some of that cost data to calculate the provider class and that additional add-on payment. One of the other elements that's really cool about the managed care programs and the preprints is that it ties into quality metrics. So there's actually quality metrics tied that are written as part of the preprint. Those end up sort of being state specific, but also utilize a lot of the industry to develop those, right? With EMS stakeholders that are working hand in hand with the Medicaid agency and potentially the EMS bureau at the state to build that quality component. And as I mentioned, the payment mechanism is an IGT, an intergovernmental transfer, that often happens on a quarterly basis as opposed to an annual one. And we'll talk a little bit more about IGTs as well. So again, very similar information, looking at sort of what an MCO payment process looks like. It's an add-on for those managed care transports. In order to participate, you sign a memorandum of understanding. So that is with the state. So it's either an MOU or in some cases, it's called a letter of agreement. And that's basically, as a provider, committing to that intergovernmental transfer process. As with the fee-for-service ASPP programs, you continue to bill, receive interim payments from those managed care organizations, just as you would without a managed care supplemental payment. Once that preprint's approved, the state ultimately invoices for that state share. And we'll, again, a couple slides will sort of show what that looks like. But ultimately initiating that IGT process that draws down the additional federal funds. And then that is returned. So both the initial state share as well as those federal matching dollars are returned to providers through the managed care organizations. So the MCOs ultimately make that supplemental payment back to the providers. These programs are developed either on cost base, which is usually going to be more beneficial to providers, given what we've seen and what we've talked about in terms of that gap, or in some cases, an average commercial rate. That is what is paid from the largest commercial payers in any given state. Again, in order to participate, it's similar requirements around being a government-owned ambulance provider, having an active NPI. Again, what is a little bit different is that annual cost report will define the provider class that's participating in the managed care supplemental payment. And that ultimately, as a governmental agency, you have to have authorization from your governing body to initiate the intergovernmental transfer process. You're signing that MOU or LOA and signing not usually a full-blown contract, but typically an agreement with those managed care organizations. What we've seen in a lot of cases is that before the program's in place, providers they'll be out of network with those managed care organizations. So the managed care organization may not even know you exist. And so this is sort of signing that agreement so that they know who to make a supplemental payment to. So what does all this mean? And what can you do, right? We've talked about really three different things. We've talked about the current ASPP programs on the fee-for-service side. Alyssa dove into what we've seen over the last 2 years, specifically in Texas, and some of the results from the audits there based on that guidance. And then what we're seeing a lot of states move towards, and where we're helping a lot of states and provider communities, is with those managed care supplemental payment programs, because again, in a lot of states, that is the vast majority of your Medicaid recipients. So it ends up being a benefit, a boon, and ultimately a significant supplemental payment for those managed care members. So we invite you, encourage you to stay informed, stay engaged. The provider community holds a lot of weight. This provider community holds a lot of weight. And so staying informed, being engaged, advocating for your department, for your state, for all of the programs and providers across the country. If you want to learn more, again, I know we threw out a lot of things about fee-for-service, current status, where things are going, managed care. You can reach us either at emsstrategies@pcgus.com. We have our blog up there, as well as both Alyssa and my email that you can reach out to us directly. Happy to, again, keep the conversation going, regardless of what status you are in the state. If you have an existing program and you have questions, if you have a fee-for-service program and want to talk managed care, if you don't have any program at all, again, all things that we help states and help the provider community with, and happy to chat more. Oh, and yes, sorry, thanks for moving that along. Sort of the specific items there. Again, certainly we can talk supplemental payments, but we have some retired fire chiefs on staff that can help. If you have other questions, right? Not just about ambulance supplemental payment programs, not just about fee-for-service, not just about managed care, but if you have questions on operational efficiency or EMS feasibility, health equity, quality, all things that we can bring in some experts to help with on our public safety consulting services. And in the middle there, I know the Medicare ground ambulance, hopefully at this point, most of you are done, able to check that box off. But if you're not, happy to help you out there as well as needed. There we go. That was the final slide.
Well, thank you both. Appreciate that. That was a lot of useful knowledge. I know that I learned a few things, even though we talk about this stuff quite a bit. So I appreciate that. I actually have clicked the wrong button and I cannot see if there's any questions in the chat. So I don't know if Nan can help out. I'm afraid I'm going to turn something off. So is there any
There
questions?
is one question in the chat. Alyssa, can you see that question?
Yeah, and I wrote a response anyways, but for the group, if your state has a provider tax, how would this affect if you did a preprint program? Great question. We've already started to do some estimates in states where there is an existing provider tax, and there's still additional benefit in all the estimates that we've done to still pursuing a state-directed preprint program. The biggest thing is that however we're looking at the data or how we're coming up with that amount, we just always need to make sure we're netting out any of that federal reimbursement that you're receiving from the provider assessment when we're, whether we're collecting data through a cost survey, because we just don't want to double count the federal dollars already received. But I feel like Missouri is probably a really good example of that. They already have I think, what is it called? A QAAP, a QAP program, I think is what it's called. And we have to net those reimbursements out of the cost report. But Missouri is also one of the states, as you saw on Garrett's map, that is pursuing a managed care program as well, just because there are so many people on Medicaid managed care. So it's really just accounting, making sure that you're not, double dipping into federal dollars or misreporting. But there's definitely still benefit from, estimates that we've done in some states that don't have any type of, specific supplemental program for public providers. I was going to say too, if anyone's brave enough and they can come off mute, we could do that as well, but we can definitely stay on for a couple more minutes if there's any other questions.
We'll give it a second on that, see if anybody pops on or types anything else in the chat. Just to be mindful that the recording, you'll receive a link today to the recorded session by email along with a brief survey. So make sure you fill that out so that if there's anything that was left out, they can add that to their presentation for the next group that they're going to do it for. But we do appreciate it. And if we don't see anybody else that has popped on, we appreciate both you, Alyssa and Garrett, for your time. And these are great opportunities for us to learn more about opportunities to get a little bit money on these tough times. So again, thank you. Thanks again to PCG. We really appreciate the collaboration with the IFC. And we look forward to seeing everybody at the next one. Thanks and have a great weekend.
Yeah, thank you all so much. Have a great weekend as well.